Hello, everyone, and thank you for joining us. My name is Ashley McDermott. I am with the AIUM, and I will be your host. As part of our continuing education for healthcare professionals, I am pleased to host this webinar, Endometriosis Ultrasound Awareness Month, presented by Dr. Matthew Leonardi. This is a non-CME education activity and sponsored by Samsung. Explore how ultrasound supports earlier and more accurate endometriosis detection. This webinar reviews key sonographic markers, expert scanning techniques, and a structured assessment method designed to enhance diagnostic precision. If you have questions for the presenter during this webinar, you may enter them into the Q&A. You will be able to submit questions throughout this webinar, but the presenter will not begin addressing them until he has completed his presentation. This webinar is being recorded and will be available within 24 to 48 hours. And now I am pleased to present Dr. Leonardi.
Good morning, good afternoon, good evening. It's Dr. Matthew Leonardi here, and I am very happy to be with you for Endometriosis Awareness Month, or as we're calling it today, Endometriosis Ultrasound Awareness Month. Thank you to the AIUM and to Samsung for facilitating this Endometriosis Awareness Month webinar. I'm going to be sharing with you all the latest and greatest on ultrasound for endometriosis and how that can be adopted in your practice. So that way you can help all of the millions of patients who are suffering from this terrible disease. And the diagnosis and mapping of endometriosis will allow them to get the optimal care in the hands of their general practitioners, in the gynecologists, and because this is a multi-system disease, in many cases, in the hands of other specialists as well. Here we go. Ultrasound evaluation of endometriosis. Here are my disclosures, and the outline for the presentation today will be as follows. We're going to first talk about the shift in paradigm from basic to advanced ultrasound and the number of organizations that we are seeing in support of that. Then we will focus on performing, which is what most of you will be doing as sonographers, and some of you as sonologists, and maybe some of you as radiologists. We're going to focus on bowel endometriosis, the sliding and the triangle sign, uterosacral ligaments and the retrocervix area where the torus uterinus exists, and finally superficial endometriosis. We're going to touch upon reporting, which may involve filling in worksheets or final reports, depending on the role you play. All right, so here we have the long list of structures that are involved in the endometriosis ultrasound, or advanced pelvic ultrasound, as I generally will call it, as a way to differentiate it from the current standard of care ultrasound that we call the basic ultrasound. The basic ultrasound terminology is, generally speaking, supported by organizations such as the AIUM historically, and supported by, in Canada, the Society of Obstetricians and Gynecologists of Canada, as well as our ultrasound societies. But every organization is very aware that the basic pelvic ultrasound actually doesn't really look for endometriosis, with the exception of looking for endometriomas. And even at that, unless we have adopted novel technologies and terminologies, we may be using outdated language such as complex cyst instead of endometrioma at the recommendation of IOTA. So here we have that long list: uterus, ovaries, and the mobility of the ovaries, the bowel, uterosacral ligaments, the perimetrium, bladder, ureters, vagina, the peritoneum, which is where we find superficial endometriosis, and finally, some of the more dynamic aspects of ultrasound for endometriosis, including the assessment of obliteration of the rectouterine pouch or cul-de-sac, and of course, tenderness. And as you can see on the right here, we have a number of organizations that have absolutely adopted and started to publish on the advanced pelvic ultrasound in North America, where we are seeing this being prime time. So Hopefully, you have some basic understanding of these novel aspects so far, but if not, here we go. And if you do, then today we're going to be really solidifying some of the educational concepts. When I started in this field nearly 10 years ago, and started to do a lot of education for endometriosis ultrasound, it became pretty clear to me that in a lot of locations and for a lot of people, there was a feeling of it being quite complicated. So, over multiple years, understanding the complexities of teaching ultrasound for endometriosis and the evolution from the basic to the advanced scan being interpreted by many as quite extreme and quite impractical in terms of implementation, performance, updates with respect to the reports. All of that put together led me and Alison Deslands from Australia put together this simplified protocol. Now, the simplified protocol takes the basic scan to a higher level, implementing some of what we interpret as the highest value aspects of an endometriosis ultrasound, but doesn't go as far as the one that is recommended by most of the organizations thus far and guided in principle by the International Deep Endometriosis Analysis Group. So you can see here in the table, there's three columns. We have the basic or the routine scan, as we called it in this publication. Next column over is the simplified protocol, where you see a few more check marks, some of the high value items, and then finally the more comprehensive endometriosis ultrasound or advanced ultrasound. And that involves everything that is recommended by the IDEA consensus group. And so this is available for free access at the journal Ultrasound in Obstetrics and Gynecology. Would highly recommend that if you are in the process of adopting ultrasound for endometriosis, you have a look at this and consider it as a stepping stone for part of your um, the next part of your process. Now, many, many years ago as well, I put together this article with George Condas, translating that four-step idea approach into what I interpret as a more pragmatic approach. You'll see the bowel is at the top, and I recommend that everybody start the advanced ultrasound with the assessment of the bowel, in part because the probe, as it enters the vagina, is able to see the bowel very clearly from the anal verge all the way through to the rectum as the probe starts to enter the vagina. And that makes it quite convenient. It takes away the necessity later on in the scan to retract the probe to evaluate that lower bowel, which can introduce some more discomfort for the patient. And finally, for me, it really reveals the level of complexity of the ultrasound very early on, and that helps me prepare myself for what I'm about to encounter and what I need to do. Thereafter, the order of things is pretty typical, I would say. The one thing that I have changed slightly is I generally speaking leave the anterior compartment to the very end of the scan, and that's because of the urine in the bladder, which aids in the assessment of the bladder, giving the bladder a little bit more time to fill up, as we always get the patient to empty before we do the transvaginal ultrasound. That's key. And then finally, my understanding of the uterosacral ligaments and the perimetrium gives me a little bit more awareness as to how I should assess the ureters in particular, which I include in the anterior compartment as they originate there. And of course, they ascend through multiple compartments, but because they belong to the urinary system, and that's primarily in the anterior compartment, I do the ureters at the end. And knowledge of the presence or absence of severe endometriosis in the posterior compartment, again, allows me to get ready for what I may need to do. Today, however, we're not going to focus so much on some of the things that are either lower yield or things that are more familiar to you, including the adnexa, because we don't have that much time, and I'd like to focus on some of the more high yield concepts. With respect to superficial endometriosis, which we will talk about today, that didn't exist in terms of our awareness back when this article was written. And so we have here a QR code for the latest IDEA consensus statement on superficial endometriosis, and we're going to definitely talk about that later today. So first things first, and if you happen to be following me on Instagram, you'll see I just did a post on this. This is my feeling. This is the most important technique, trick, whatever you want to call it, for endometriosis ultrasound. It's the positioning of the probe into the posterior fornix, which we call the posterior approach. So with the application of pressure downwards into the direction of the ground, you go behind the cervix. And once you're there, you have to maintain the pressure, whereby you're stretching the vagina and then the contents of the posterior compartment over the probe. You have to maintain that pressure as it is quite easy to fall out of that space, easier when there is anatomical distortion from endometriosis. And so you have to really maintain that pressure and you keep your eye on the vagina to make sure that the vagina is all in view and still very stretched out. This is the most important maneuver. So let's talk about the bowel. The bowel has several sections. We talk about the rectum, which is divided into the lower rectum and the upper rectum. That division is the peritoneal reflection, roughly at the level of the fundus of the uterus, roughly around 15 to 18 centimeters from the anal verge is where the rectosigmoid junction is. And that's a junction, it's a transition point. But there are a few centimeters there, which we call that rectosigmoid junction. And then anything above that is the sigmoid colon. And you can see here how the IDEA consensus statement divides those by the colors. And you can see on the right, the recommendation, and this is true for all types of endometriosis nodules, they should be measured in 3 orthogonal planes. So when we talk about that peritoneal reflection and the division between the lower rectum and the upper rectum, this image that I have created can really help us with those anatomical landmarks. So here, as recommended earlier, we are in the posterior fornix. So this is the posterior approach. We're stretching the vagina over top of the probe, and we're benefiting here from some fluid filling the pouch or cul-de-sac. And we can see that just on the other side of the vagina, there's some peritoneum and there's some fluid, which tells us that this is the intraperitoneal aspect of the pelvis. But that ends here at the peritoneal reflection. This is where everything beyond is considered retroperitoneum, including the rectovaginal septum, that's here, and the rectum on the other side of the rectovaginal septum, that's the lower rectum. You can see where we draw that line, and we can see where our lower rectum is and our upper rectum is based on that line. I use these different anatomical landmarks for describing where endometriosis is, if it's of the peritoneum itself, if it invades into the vagina. Really, truly, the invasion into the rectovaginal septum is, in my opinion, incredibly rare, possibly doesn't occur, but more likely incredibly rare than it doesn't exist. As in medicine, we know that there's an exception for every rule. And then when it involves the rectum here, that could involve just the serosa if we see small little abnormalities on the serosa, or it can involve the muscularis there, which is below that. And you see that that's the image from the IDEA consensus statement, giving us the divide between those two areas of rectum. Now, when we look at the rectum specifically, we have several layers of the rectum. The serosa is the hyperechoic layer on the outside. And again, in this particular image, we are benefiting from the presence of fluid, and that can give us a little bit of acoustic enhancement of the wall of the rectum, the several layers of the wall. Beyond the serosa, we have the muscularis, which is made up of outer muscularis and inner muscularis. Outer longitudinal, inner circular. I remember that because the second letter of longitudinal is O for outer, and the second letter for circular is I, inner. And then there is a white line that divides the two of them. And that white line is not particularly yet well described in the literature for endometriosis or for ultrasound for endometriosis, but it can really give us a little bit of a sense of whether the nodules invade all the way through both layers or are on the outer layer. You would never see an inner layer lesion without an outer layer involvement, because endometriosis is by definition an intraperitoneal disease, meaning with structures such as the rectum, the bowel, it's going to land or exist on the serosa, and then it's going to infiltrate in the direction of the lumen. The same would apply, let's say a lesion landed on the peritoneum overlying the vagina here, it would infiltrate into the direction of the vagina. So you would not really have a vaginal lesion without any involvement of the peritoneum because it has to begin in that area. No, sorry, continuing with the rectum layers, the mucosa is the final layer, and that's the white layer on the inside. And that is then repeated on the other side, but the lumen is the cavity of the bowel. Now, I have a full 30-minute lecture on the bowel itself on my YouTube channel, so you can check that out there. But the goal and the steps of assessing the bowel is to first find the rectum muscularis at the anal verge, and I do that at the very beginning of the scan. I follow the bowel wall, and at this point, because the bowel wall is parallel to the floor, my probe is really angled towards the floor, and that allows me to very naturally enter the posterior fornix to achieve that posterior approach. We're going to follow the black line in its entirety, and this is going to involve very slow side-to-side movements, no more than roughly 10 degrees of lateral shift. There should be no rotation of the probe. You never assess the bowel in transverse. You don't need an oblique rotation of the probe to assess the bowel. It's always in sagittal 0 degrees, but the side-to-side shift can be considered roughly 10 degrees from the midline point. And of course, most of the scan for endometriosis is going to involve staying in the posterior fornix. But as you ascend the bowel and follow it proximally from rectum to rectosigmoid to sigmoid, you, generally speaking, have to come into the anterior fornix as you have a limited ability to apply ongoing pressure in the posterior fornix to see that bowel. And sometimes you see the rectosigmoid and the sigmoid really nicely through the uterus rather than from the posterior fornix. And if you get lost, always restart. Find your restart position, which may be back at the anal verge, and that allows you to continue to achieve your objective, which is complete assessment of the muscularis. So here we have the first move. So we found the bowel at the anal verge. We're ascending. You can see the vagina is splaying open, anterior and posterior. And so that is the first part of the bowel assessment. So that's the lower rectum there. And then once we do that, we follow it side to side, that 10 degrees. I think of this from an aerial perspective. Imagine you're looking directly down on the patient, and every few centimeters, you're going to ask yourself, which direction is the bowel going? Is it going left or is it going right? Is it going left? Is it going right? Is it going left? Is it going right? Etc. And that will allow you to naturally follow the bowel. Eventually, it becomes, and in some instances more than others, a very natural flow where the bowel is quite easy to follow. You can see in this clip here, we're following the bowel wall. We're keeping our eyes on the black and on the black that is closer to us. That's the anterior muscularis. We're following it. We're following it. We don't take our eyes off of it. And you can see actually how much length we're following here. So as stated, the probe should be in the posterior fornix in that position. However, if you have a retroverted uterus, the probe is generally speaking already naturally settled into that posterior fornix. So you don't have to make that extra move. And here we have an anteverted uterus. And so in any anteverted uterus, the probe, generally speaking, naturally settles into the anterior fornix. You have to make a very concerted effort to position that probe there. I've already shown you that move once, but here it is again, because it is so important. You can see how close you bring the bowel to the probe. It's practically touching the probe once you do that. And so that maneuver is key. And so in this case here, we have an abnormal bowel. We have a muscularis layer nodule. We can see the normal layer of thickness just at the top of the image. And then all of a sudden we see the splaying or the increase in thickness in this region here, and then we see where that bowel normalizes in terms of its thickness just here. So this is the bowel nodule, and I show you here the surgical depiction of that, which truthfully, very few surgeons would be able to understand that there is indeed invasion of endometriosis into the muscularis. We see on the surface of the bowel here, and this is the uterus, which it is attached to. We see this abnormal area here. That's endometriosis. However, you don't have X-ray or sonographic eyes at surgery to be able to see that the endometriosis is actually invading quite a few millimeters deep into that muscularis there. And here's another depiction of a bowel nodule. These are quite classic bowel nodules. You'll see here we've chosen to trace the length of the lesion as it is quite C-shaped. The more C-shaped it is, the more important it is to use trace or spline function, as a straight line will underestimate the length of bowel. And should this patient be pursuing surgery, we want an accurate representation of the bowel length involved so the surgeons can determine the correct surgical procedure. Now, we'll get into this a little bit later, but I do want to point out here that between the probe and the bowel are a number of hypoechoic areas, and these areas here are all also endometriosis. Now, this, I bet, historically would have been called a lot of rectovaginal septum endometriosis because it's seen as between the rectum and the vagina. But the rectovaginal septum is much more low or caudal, where I'm pointing on the upper right aspect of the ultrasound image. This here is still considered intraperitoneal, and this would be considered either uterosacral ligament endometriosis or pouch peritoneum endometriosis. And because of the inflammatory nature of this disease, these become sealed together. And when it comes to surgery, these areas of endometriosis appear to be in a space that is an enclosed space, or in maybe another way of thinking of that, in the retroperitoneum. But in fact, this has artificially sealed in a way that makes it feel like it's in the retroperitoneum, but it's not. And here's another clip here of a very long bowel nodule. You can see the normal down here, and then you can see how long this lesion is. In most cases, you can appreciate the full length of a bowel nodule in a single image, whereby you can get a full measurement of it. But indeed, in some cases, you actually do need to take it in 2 images in order to determine the entire length of it. Remember as well, when there are more than one lesion, you should try to identify the normal bowel in between the lesions and measure that distance as well, so as to inform the treatment team how much bowel length is involved in total, from the topmost point of the topmost bowel lesion to the lowest most point of the lowest bowel lesion. Here's another clip and still next to it. And you can see here in this that this bowel has more or less enclosed itself. This lesion is very C-shaped, and it has sealed itself off from the outer environment. That is the structures usually that the bowel is in contact with, such as the cervix or the peritoneum. And when this happens, these bowel lesions don't tend to result in severe adhesions within the pelvis because they are adhesed to themselves. They close off, and these are more or less impossible to find surgically. So really, when people talk about surgery as that gold standard, as the only way to diagnose endometriosis, in fact, surgery has a lot of flaws with respect to mapping endometriosis and certainly determining the extent of lesions, because we, again, don't have sonographic vision when we operate. So this is a really key type of lesion to identify sonographically. And this is another example of a very similar situation, and I'm going to show you the surgical footage of this one. So here we have the bowel lesion. We can see as we apply and release pressure, that bowel lesion does not appear to be stuck to the peritoneum. There seems to be a separation of those structures. And so we go to surgery. This is the patient at surgery. And believe it or not, and I know probably many of you are not surgeons here, so you may just be trusting my word. This here is the area of endometriosis. This is epiploica, bowel fat. This is the bowel serosa right here. And the endometriosis is just buried underneath here. And what's happened is these epiploica have more or less closed off this area of inflammation uh, in a way that it protects the architecture and the health of the rest of the pelvis. So it's done a very good job of doing that. But from a surgical perspective, it makes it very difficult to see. But we knew it was there from the scan, and we had already committed to undertaking a low anterior resection. And that you can see here is the segment of bowel has been removed. You can see that the area that I'm squeezing is exactly the same in appearance as the lesion from the sonographic view. So we knew it was there, and we committed to this with the patient's consent. All right, so moving on to the uterus and the sliding sign, which is something you're already very familiar with. We'll go through that very quickly. The point is, I want you to understand some issues that the IDEA consensus statement failed to address with respect to the retroverted uterus. So here we have an anteverted uterus, and we're using the ballottement technique. And this is what a normal cul-de-sac or rectuterine pouch looks like at surgery. You can see there's no adhesions. And with the ballottement, the pressure applied to the uterus fundus, we can achieve that sliding very effectively. You can see how still my probe is. I try to maintain that the mid-sagittal view the entire time. Here's another technique. This is with the application of pressure, again with the hand up top, and you can see we are not eliciting that same level of sliding. Of course, the structure of the uterus does still move. It still can shift a little bit, and we have to just pay a lot of attention to the serosa at the back to assess whether there is sliding with respect to the structures, and we can see that indeed there is not here. And so this is a case of an obliteration where we have severe adhesions between the uterus and the structures behind it, in this case, partly the ovaries and partly the bowel. This technique is the application of pressure technique with the probe rather than with the hand. And you can see that, again, we are not eliciting movement. Generally speaking, this is not my preferred technique if the ballottement technique works, but in some instances, this is more effective. You do really have to get a sense of which is going to be more effective with experience. And sometimes you use both and try and record for both. But you must remember that the default situation is the uterus and the bowel won't slide against each other if there is not adequate pressure or pressure applied in the correct location. And so if the technique was not performed well, then it is very easy for us to see a false positive negative sliding sign. And that's not very good because that then gives people a very significant false impression of how severe this disease is when maybe, in fact, it is not. So with respect to the retroverted uterus, there is a failure in the IDEA consensus statement to appreciate the space behind the serosa of the uterus between the vagina and the serosa, and that space is shaped as a triangle. And so we see here in this video the retroverted uterus with the application and release of pressure, we have fluid filling that space. And that fluid allows us to understand that there's no adhesion between the serosa of the uterus and the peritoneum overlying the vagina. In contrast, the negative triangle sign does not permit any fluid to fill in this space. As we apply pressure and we release pressure, we do not see any of this free fluid that you can see just to the right here of the fundus of the uterus is not filling the space. We can also appreciate that in this particular clip, the uterus and the rectum itself are sliding with respect to each other. So that's positive sliding sign at the level of the fundus. And the area between the uterus and the peritoneum overlying the vagina has endometriosis within it. All right, let's move on to the posterior compartment, which is the highest yield area for endometriosis. This involves the posterior vaginal fornix, relatively rare, uterosacral ligaments and torus uterinus, not rare, and rectuterine pouch peritoneum, also not rare, and in fact, the most common location for superficial endometriosis. The pouch peritoneum has been a relatively ignored area or anatomical landmark. And so I think this is a really important one for all of you to understand. And we're going to talk about it in relation to some of the other structures as well. So here we have a surgical and a sonographic depiction of uterosacral ligament deep endometriosis on the right of screen. We have our nodule there, which you can see the calipers, and we can see on the left of screen the induration, the bulging of this in comparison to the left side, which does not have that same level of bulging, but absolutely there's superficial endometriosis there. And so when we look at the surgical anatomy, the torus uterinus is the area behind the uterus. This is the uterus, this is the cervix, this is where the uterosacral ligaments come in and are meeting. The torus uterinus is that area. The pouch peritoneum or cul-de-sac peritoneum is this peritoneum below the level of the torus. It's on the other side of the vagina, and the rectum here, which is mostly covered with some free fluid and blood. There is the rectum just there. You can see the division between the white and the yellow, and that's where the peritoneal reflection is. That white and yellow division is the true base of the peritoneum of the pouch. And so you can see here that these are in direct connection with each other. And in fact, I think of these in some ways like a spectrum because there's not a clear division always. And lesions can take over more than one anatomical landmark crossing the borders as well. So here we have a sonographic depiction of a nodule, and that nodule is exactly between the torus and the pouch peritoneum. That nodule, just for clarity, is right here on the sag view and right here on the trans view. And you can see here, this is the cervix, which we know the torus is at the back of, and this is the peritoneum on the other side of the vagina. This lesion seems to be exactly at that division point between the two. And so we can describe this lesion as crossing the boundary of the torus and the cul-de-sac peritoneum or pouch peritoneum. Here's a video of this particular nodule. Just here is the lesion. And you can see that the positioning of the probe in the posterior fornix, the posterior approach, allows us to bring that nodule right in direct contact with it. But in comparison, sometimes we can see the torus lesions really well through the cervix. And so here we have a uterus that's anteverted and retroflexed, and we have this ear shape, which we've talked about a lot over the past years, in the context thought to be related to adenomyosis, but in fact probably is more often than not related to adhesions pulling the fundus back into a folded shape. And so I'll draw your attention to this area at the retrocervix, where we have an area of torus uterinus, deep endometriosis, and you can see that the fundus of this uterus is actually being pulled. The planes here are lost, and so it's sort of becoming a little bit of a uterus taco, with the content of the taco being the endometriosis, causing that fold to occur. So here's that image again. And so it's not just a spectrum in the vertical plane, but it's also a spectrum in the horizontal plane where the uterosacral ligaments come into the torus uterinus. And even though the posterior approach is my favorite approach, I do think that sometimes coming into the anterior approach to look through the cervix to these areas behind the cervix can be very helpful. And so what we're seeing in this clip here is this lesion is at the torus uterinus right here. And if you keep your eye on that lesion, it actually extends all the way to the right uterosacral ligament. So this lesion traverses right uterosacral ligament and torus uterinus. When we take the posterior approach to evaluate a lesion such as the one you just saw, you can keep your eye on it in the sagittal plane sweep. So what we're seeing here, exactly where the arrow is pointing, is a deep endometriosis nodule. And this sweep is actually occurring from one side through the torus to the other side. And that lesion is present the entire time. If you take your eyes off the lesion and you look a little bit deeper into the image, you can also see over the course of this image one ovary in view with an endometrioma and then coming to the next ovary. So both ovaries are pulled in and under, attached to these lesions behind the uterus in the pouch peritoneum. We can call these horseshoe nodules because they're shaped like a horseshoe across uterosacral ligament, torus, and contralateral uterosacral ligament. That's that same lesion there from the anterior view. I always like finding these lesions much better from the posterior approach, but getting that global perspective whereby you can see the right ovary, left ovary stuck to this lesion, you can see the relativity to the cervix. It becomes very nice and clear from this perspective as well. Now here's the uterosacral ligament in its normal case, which you have not yet seen because I've just shown you abnormal ones and normal peritoneum. And what we're doing is in the posterior approach, maintaining the pressure and lateralizing the probe. I don't change my degree of rotation until I reach the uterosacral ligament. But it's always a medial rotation. The notch should rotate towards the inner aspect or medially. And usually it's a very subtle degree of rotation, no more than 45 degrees to achieve this full length longitudinal view. When there's fluid present, that fluid can sometimes help you. This is not an adhesion, this is a uterosacral ligament. And if you were to apply sufficient pressure, you could push that fluid out, bringing the uterosacral ligament in continuity with the peritoneum of the pouch that's just here. But allowing that fluid to fill this space can be really instrumental in not only helping understand the anatomy, but finding subtle lesions on the surface of the peritoneum in this little space between the uterosacral ligament and the pouch peritoneum. This little space you can't really see surgically because you have to look around it. There is a space underneath the uterosacral ligament here between the pouch peritoneum and the uterosacral ligament, and sort of a little bit on the left side as well. You can see that there's a tiny little space just under there, and that's where that fluid is collecting, and that's what we see sonographically. And here we have an abnormal uterosacral ligament, so the technique is applied the same always. And we lateralize and we rotate and we see the nodule just coming into view there. Hypoechoic lesion interrupting that hyperechoic band structure of the uterosacral ligament. And if we fast forward this clip a little bit, we come back to the beginning and then we go to the other side, we see another lesion just coming into view right here. That's the other side. These lesions are deep endometriosis lesions of the uterosacral ligament. In a retroverted uterus, many people think it's much harder to evaluate the posterior compartment. It's actually not, because the posterior compartment is much easier to see from the posterior approach. And as I said earlier, the probe already settles into the posterior fornix in a patient with a retroverted uterus. So in this particular clip here, my sonographer has more or less recorded a cine loop of the uterus. But in the cine loop of the uterus, we have both uterosacral ligaments, and we have the vagina, and we have the torus. All of those structures are already in view. Between the uterosacral ligaments, that thin peritoneum right there is the peritoneum of the pouch. So all of these structures, there's the peritoneum, are already in view. Uterosacral ligament coming into view there. You can see the relative change in thickness. Uterosacral ligament right there. They're all in view. So take advantage of the retroverted uterus and start to draw your eyes to the space between the uterus and the probe rather than exclusively looking at the uterus. And in this particular case here, this is another cine loop recorded of a uterus. This is a transverse cine loop. This is a very interesting case because endometriosis was not anticipated but picked up incidentally. This happens quite a lot now. When we are moving through this cine loop here, I'll pause right there, we can actually see uterosacral ligament endometriosis on the right, on the left, and you can even see a little connection, a little bridge across the torus uterinus there, which indicates that this is indeed a horseshoe lesion across both sides. So we're not going to have very much time to talk about the bladder, but I will talk to you briefly about the ureters because they're fun and interesting. And the ureters can be quite impacted by endometriosis. So this is a normal ureter here. And the approach to find the ureters is as follows. Draw an imaginary line on your screen, dividing it in half. Connect the bladder to that line, but don't allow the bladder to cross the line. In order to do that, you need to be, generally speaking, in the anterior fornix in a mid-sagittal plane, the cervix and the endometrium in view, and you apply pressure, and then you do not change your pressure at all. You do not change your angle of the probe. That's the beautiful starting point right there. and you simply lateralize the probe. The ureters are more lateral than you think, so you have to keep going, and there it is. And usually you don't really need much of a degree of rotation to be able to visualize the ureter. You want to try and follow the ureter beyond the crossing of the uterine, which you can see the uterine is here and here. That's the crossing of the uterine and the ureter right there. That's the uterine, and the ureter is just there. You really want to follow the ureter beyond that crossing, so that way you can ensure that at the most common location, which is the perimetrium, uh, there's no constriction of the ureter, resulting in hydroureter more proximal to that. Site-specific tenderness, I only want to say one thing about, which is that it is more likely site-specific tenderness is present in people who have myofascial pain, which is a pain generated from muscle-related issues, rather than from endometriosis itself. Many patients with endometriosis have what we call peripheral sensitization, and they have resultant myofascial dysfunction, which results in pain from those muscles. Just like anybody can have low back pain from muscles or upper back pain from muscles, pelvic floor muscles can generate pain. And so please be very delicate in diagnosing endometriosis if site-specific tenderness is the only thing identified, because really, truly, it's more likely that this patient has a muscle-related issue, which could be from endometriosis, but also could be uniquely generated from other issues, including other inflammation processes in the pelvis that are bladder or bowel related, or past trauma experiences. And so we want to be very delicate about site-specific tenderness and attach it more to a true pain generator, which is the muscle, rather than the endometriosis itself. Now, superficial endometriosis will be the last part of our talk. And so it can be anywhere in the pelvis, anywhere in the body, truly, but it does have patterns, and the pouch and the uterosacral ligaments are the most common locations for it. We're seeing tons and tons of literature coming forward on this subject, so lots of online resources for you. I've included some of the main articles just here, and earlier I shared with you the IDEA addendum QR code. So hopefully you can take some independent time to learn about this. But let's talk about how it looks surgically and then how it looks sonographically. We see here that the appearance of superficial endometriosis in every one of these patients is very different. We have red lesions, blue lesions, brown lesions, clear lesions. We have lesions that seem to project more outwardly versus ones that are more flat. We have ones that are creating filmy adhesions in the upper right, and in the bottom right, we have a peritoneal pocket. Peritoneal pockets are defects within the peritoneum that are caused by usually endometriosis, and fluid fills into those spaces, and those can be quite multi-loculated, if you will, although truly the various segments or pockets are connected to each other, but there can be multiple sort of sections to those peritoneal pockets. We can describe superficial endometriosis as a hypoechoic area without really any depth of infiltration, hyperechoic projections that are coming off of the peritoneum, and those can have movement or no movement, jiggling with the application of pressure. And then you can also have cystic areas present. Indirect descriptors of superficial endometriosis include the pockets of fluid and filmy irregular adhesions, as these are not direct findings of endometriosis, but actually the after effect of the presence of endometriosis. And it's through the presence of fluid, which you can introduce through a modified sonohysterography or SIS, which we call a sonopodography, saline infusion sonopodography, or you could hopefully be opportunistic and identify fluid when the patient has natural peritoneal fluid present, allowing the peritoneal surfaces to be revealed. And that's what we're seeing right here. That fluid presence, as we move the probe slightly side to side, allows us to visualize this hyperechoic focus, quite possibly a very tiny cystic lesion. Sometimes the cystic lesions are so small that you don't really see the wall of the cystic lesion or the interior fluid contents. You just see this focus. But sometimes they can be a little bit more obviously large with fluid within. And that lesion As you see, we're lifting the cervix on the far left here. That's what we're seeing sonographically. And here's another case example. And this is actually a 12-year-old patient who, with her mother, consented for transvaginal ultrasound using the mini probe, which is a really fantastic, novel tool from Samsung, applicable on the V8 and the Hera Z20. And you can see that we're seeing this irregular focus, and it is, in fact, jiggling with the application of pressure. You do need to ensure that you have determined whether the patient has any history of surgeries or whether they have any history of inflammatory processes or infectious processes, whereby these features could hypothetically be from a different process, but in the absence of those, endometriosis is the reason. You can see how this looks very much superficial, hanging off of the back of the cervix in that region, and that's what we would see. Here's another example. Along the uterosacral ligament, we have a hyperechoic focus, and it is jiggling with the application and release of pressure. That's what we're seeing there. This area just here. Rather than hyperechoic, we can also have breaks in the peritoneum. You see this, the hypoechoic region just along the surface here. That's this case just here, and this is the area that we're seeing. Very similar, in this case, a hypoechoic area, very subtle, superficial hypoechoic area with some associated hyperechoic foci. You can see in all cases there's fluid present. Here we have another case of hyperechoic foci, but in fact, we have many of them all at the same time, all very close to each other. And so this is what we call a cluster, as per the latest IDEA consensus. And we describe this as a cluster of hyperechoic foci. We can indeed see anterior compartment superficial endometriosis as well, though a bit more rare for fluid to settle into that space. But when it's present, you should take the opportunity to evaluate it, and you can see these features. In the anterior compartment, you do have to be very careful if a patient has a history of a cesarean section that we don't describe these features as, of course, somebody has already been there, cut through the peritoneum, cut through the uterus, can result in some irregular features in this region. All right, here's another case example of hyperechoic foci. We have two little lesions right here next to each other, 1 and 2, and those are represented in the surgical depiction. All right, so you can see how active I'm being with the probe here to elicit the way that the filmy adhesion moves with the fluid. This is a not normal feature. Of course, the fimbria of the fallopian tube can do this, but they're not very long and they're not crossing from one structure to the other. And so trying to demonstrate through videos or stills, this is key. And here's a depiction of a peritoneal pocket. You can see that this patient has some low-level echogenic fluid within the pelvis. You can see that this pocket has multiple different compartments to it. When one applies too much pressure, it is possible to push the fluid out of the pocket, but most of the time not. And these can be quite low in the pelvis, in the pararectal space, and invading into the retroperitoneum, into the pararectal space, even below the peritoneal reflection. So sometimes you have to really look into that low aspects of the pelvis, resulting in the probe pointing almost to the ground again. This is another example. Peritoneal pockets are actually quite common. And you can see that there's channels open between each different little area. So if you apply some of the concepts from iota, which looking at complete septations versus incomplete septations, pockets by definition have incomplete septations, allowing the fluid to move between the various sections. And here's the final peritoneal pocket, an incredibly subtle peritoneal pocket, pointed out in the video there. And surgically, we see this little pinpoint area just right here. When we go to surgery, we apply pressure to the area. We can see that that fluid spills out there, which is pretty crazy, just small little indentation. And we can, of course, then plan to excise the area within the pocket, which is where the endometriosis is hidden, which is what we're doing here. We go into it, we open it. We can see in a second the little brown spots right there at the top, 1, 2. And those 2 spots represent the 2 hypercoag foci we formerly saw in the clip of the ultrasound within the pocket. And so we can excise that pocket in its entirety. Now, just at the very end, I want to give you this resource because I have integrated my intake form for my ultrasound clinic into this publication, as well as my ultrasound reporting template into this publication. And it's free access on the website in the supplementary material. So I would encourage you to consider using it as it is evidence-based and quite updated, although to be honest, things do move fast and furious in the space of endometriosis. So there are chances that this could be updated even further in the coming weeks, months, years. And this is what my ultrasound report looks like. So focusing more so on the endometriosis aspects, when it comes to the ovaries, we talk about mobility. That's a feature of the scan. When it comes to the other structures, including the uterus, the endometrium, we follow the other international guidance documents, including MUSA, AIDA, IOTA. When we break down the various compartments, we can see here it's broken down into anterior compartment and posterior compartment. At the top of the page, I do indicate whether the presence of fluid has enhanced our ability to evaluate for superficial endometriosis or not. When we document the deep endometriosis lesions, we do so by location and with measurements and give a little bit of qualitative information as well. If the bowel is including a bowel nodule but not adherent to anything, we may indicate that. The sliding sign and the triangle sign are present here. Triangle sign is only applicable with retroverted uteruses, so the smart forms that we have allow that to pop up for us to assess when retroverted uterus is selected. And you can see the beginnings of the impression list down below. So this is what it looks like. And then when a scan is performed by myself or one of our clinicians, we do provide feedback in real time to the patients as to what we have found. And then that can give them a little bit of reassurance as to what is there or what is not there, and going back to their referring provider for ongoing care. I would like to remind you, this is one of the most important messages. A normal scan does not equal a normal patient. Patients who have pain deserve to be validated, deserve to be fully investigated as far as they would like to go, and they deserve treatments as well. We should never normalize a patient's symptoms because a scan does not identify something. And in particular, that's true of superficial endometriosis. When we know we can see it, but we cannot rule it out. In the hands of myself and my team, I believe we can rule out deep endometriosis, although I think each individual team has to make that determination themselves. But consider something like this statement at the conclusion of a normal scan as an attempt to help prevent invalidation of patients' symptoms. It is important to remember that a normal ultrasound does not mean the patient is normal. It simply means we have not identified an anatomical explanation for the patient's pain on today's scan. On the other hand, a normal scan can be considered reassuring because there's no deep endometriosis, there's no adenomyosis or fibroids or adhesions or ovarian lesions. And so we do need to determine how we optimize the use of the language of a normal scan whilst not invalidating the patient. And it may be that we really hammer home to the patients that we have ruled out some of the really terrible pathologies, the things that they absolutely do not want, like deep endometriosis or ovarian endometriosis. Superficial endometriosis is not a good thing to have, but if one does have endometriosis, it's the best subtype to have. We can tell people that nothing dangerous is happening and that their tubes are functional without any adhesions, for example. Their uterus and their endometrium would be potentially optimistic from a fertility perspective. So it is good news in the end, and it is optimistic news. And if we just touch very slightly on some pain science principles, each of us has a protectometer, signals that we listen to and determine whether it's danger or safe. And we can try to help patients understand that a normal scan should elicit safety in me concept rather than danger in me concept. And so that can be something helpful to understand. When patients do end up pursuing surgery, for example, this normal scan should mean that the surgery should be relatively straightforward or lower risk, at least, without any real concern of damage to ureters or bowel, for example. When patients have a normal scan, if you are a gynecologist, the latest guidelines and even the older guidelines have always encouraged us to consider empiric treatment, even when scans are negative. In that, we understand we cannot rule out this disease and the clinical symptoms may still point to it. So, therefore, we should still consider treating patients. All right, so take home messages. Following the systematic approach is key, guided by idea, but do consider some of the other latest guidelines that are coming forward and do consider the simplified protocol as a stepping stone for implementation. Do keep in mind that things are going to be changing and we're going to be having more and more talks on this in the coming years. Practice the posterior approach, practice at following the bowel. Don't jump all the way into it and think I can do a whole endometriosis ultrasound, advanced ultrasound. Take it step by step. And if possible, try to have a feedback loop that's closed with respect to the surgical findings or the pathology findings. I have the benefit of being a surgeon sonologist. I learn about what I find when I operate, if I operate on certain patients. And so if you're a sonographer, radiologist, try to optimize that communication. And of course, a normal scan should not invalidate a patient. Thank you so much for your time. I hope there's a little bit of time for Q&A now. I have some QR codes here that you can use to access resources or the various podcasts I've been interviewed on. And of course, here are my handles for the social media where you can find lots of free educational content. Hello, hello, everyone. It is great to be here live now with you. I hope that you enjoyed the recorded lecture, which obviously was very comprehensive, but still not 100% comprehensive when it comes to the ultrasound evaluation for endometriosis. It is a growing field, and there are so many subjects that we could have expanded upon or included that just there was not enough time for in a nearly 1 hour lecture. I'm going to take some time now to answer the questions that are in the Q&A box and also have a look at the webinar chat where there's some content as well. If you are still thinking of your questions, pop them into the chat box now. And if there's not enough time to get through all of them, what I will try to do is get the questions from the AIUM team and go on my Instagram story later and answer those remaining questions. So if you are on Instagram, you can follow along and get the answers to the remaining questions later on. All right, so we'll start at the top. And actually, I know I probably said it at the beginning, but thank you again to the AIUM and to Samsung for their support and coordination. Really fantastic teams to work with, really very coordinated and organized. And this platform is really fantastic. So thank you. And thanks to all of you for being here. All right, Courtney Vale. What are your thoughts on shaving when endo invades the muscularis? I feel like lesions are still present after surgery if they are just shaved. Really great question. Muscularis layer lesions, which is really the definition of deep endometriosis of the rectum, are usually not going to be amenable for a complete excision with shaving. In order to get the entire muscularis, you really need to get down to the level of the mucosa, and the mucosa is almost paper thin. So whenever there's a true muscularis lesion that extends through the entire muscularis, including the inner circular layers, you almost inevitably have to make an enterotomy, either through a discectomy or through an anterior segmental resection technique. So I do not believe that there is a rule for shaving when it is a muscularis layer nodule. There are some potential places for shaving, which could be when only the outer muscularis is involved and the inner muscularis is maintained. And I use that white line to help me try and make that differentiation. Or in the rare instances when the endometriosis is only on the serosa of the rectum and not invading into the muscularis at all, which to be honest is very difficult to see on ultrasound, but possible if there's some fluid present. So yes, absolutely shaving is a technique that needs to be used very specifically, and we need ultrasound to tell us when we could use it and when we shouldn't use it. All right, I'm gonna just for fairness, because Courtney had a lot of good questions, I'm gonna jump to the next question and then I'll come back to Courtney as well. And I see that people are putting stuff in both boxes. If you want to do questions, try and pop them into the Q&A so it's a little bit easier for me to stay organized. Ahmed says, what about parametrium endometriosis? Yes, actually. So that's sort of one of the points I tried to make at the very beginning of my live part here. This is a distinct subject, all in and of itself. I just actually recorded for another purpose a 30-minute talk on parametrial endometriosis and assessment of the parametrium specifically. But there are a few really fundamental aspects that were touched upon in this that are the jumping off points to the parametrium. So I think the two main structures to really understand, which is going to help you master the parametrium, are the uterosacral ligaments and the ureters. The ureters travel through the anterior parametrium and the lateral parametrium, and they're often blocked at the lateral parametrium. So, following that ureter is a really key technique that you need to know how to do. And then understanding the uterosacral ligaments will allow you to understand when you have posterior parametrial endometriosis. That could be going in the direction of the pararectal fat, into the direction of the sacral plexus, for example, although that is rare. Shade, hi Shade, nice to see a familiar name here. How long does a complete scan typically take, and how do patients with endometriosis generally tolerate it? Depends on who's doing it. I've been scanning now for many years, and if the scan is entirely normal, whereby I'm not measuring things like fibroids, I'm not measuring adnexal lesions, I'm not measuring multiple deep endometriosis nodules, I actually think I can do a complete endometriosis ultrasound in probably under 7 minutes from the start of the scan to the end of the scan. Obviously, there's a little bit of time for the setup, the patient to get undressed, empty their bladder, get into position, all that. And then on the flip side, when you have pathology in multiple organs, uterine pathology, adnexal pathology, tubal, you have multiple endometriosis lesions, adhesions, then you can be scanning for probably 30, 40 minutes of scanning time. And that's a lot. It's long and it can be very tiring. Your eyes can get exhausted, and your brain can really get a bit tired as well because you're trying to take what you know from normal and understand how all of this anatomical distortion is changing the pelvic architecture and where all the lesions are. And so it can be quite long. Um, like most things in medicine, you probably end up breaking even. You have one easy patient, then you have one hard patient, then you have one easy patient, you have one hard patient. It kind of comes back to the mean. And how do patients tolerate it? They tolerate it a variety of ways. Some people, you put the probe in and they're jumping off the table and you actually can't complete the scan. They have severe myofascial pain and they need to do a lot of work with respect to pelvic floor physiotherapy. They may need some medications prior to a scan and then may be able to reattempt that scan. And then some people are just there and, they are perfectly fine and they don't have the myofascial component, which is probably the biggest generator of discomfort during the scan. But patients also come to that scan with a lot of emotions, a lot of anxiety. I think many of you in the room who are surgeons who understand what it's like to tell somebody that they don't have endometriosis. These patients are really worried about another thing that's just going to invalidate them. So we have to keep some of those things in mind because that actually goes into how a person tolerates the scan. I'm going to quickly answer Amanda Ditty's question about the CPT code because I am not in America, so we have a different coding system in Canada. But more or less, the approach that we've taken is take the fundamental gynecology ultrasound codes, which include transabdominal imaging codes and transvaginal imaging codes, and then I add on to that what we call limited abdominal code, which is not a full abdomen, which would include, liver and everything, pancreas, etc. We're assessing the ureters, the bowel, and on occasion the kidneys. So we add the limited abdominal code, and that has been possible for us to do. I'll come back to Courtney. Um, do you see the question mark sign go away post surgery? So, the unfortunate reality with those who have severe adhesions that are originally causing that retroflexion, after you try to normalize the anatomy at surgery and you excise the endometriosis and you may perform a segmental resection, for example, you do often get recurrence of obliteration. Adhesions form not necessarily from new or recurrent endometriosis, but from surgery. Full stop. So it's not unusual for the question mark sign to be maintained because the uterus just simply kind of gets stuck back into that position. But usually, if you have, and one of the images I showed was that really triangular shaped torus nodule. If you excise that, usually that triangular shape will dissipate. And you actually see that moment happen in surgery sometimes where that uterus, which is folded over almost like a taco, is kind of released. And obviously, well, maybe not obvious because I'm sure there's many sonographers here in the audience. We use a uterine manipulator in surgery to help with changing the angle of the uterus, anteverting it, moving it around. And you can usually see in the moment when that adhesion is released that you get that maximum anteversion with whatever uterine manipulator is using. You see it happen. And if you get to that point in the surgery, then usually it does not recur into that question mark shape. But then you may end up getting downstream recurrence of adhesions, which could cause that to happen again. All right, let's come to Ahmed's question about the sacral plexus. So, I mean, it's not a very specific question. What about sacral plexus endometriosis? What I can say on this is um, for many years, we didn't really have an understanding of our ability to see the sacral plexus on ultrasound. We definitely can see it and actually can see it very clearly. And there is a standardized approach to finding it published by Gabor Szabo and Daniela Fischerova in Europe, and you can find these publications in the Ultrasound in Obstetrics and Gynecology Journal. This is not that hard actually to see, but parametrial endometriosis can be quite challenging, and it is an extension of parametrial endometriosis that becomes sacral plexus endometriosis. When I see these, mostly because it's still quite novel to assess on ultrasound, or if I have significant concern and I'm not 100% sure on ultrasound, this is one of the very few places where I will still ask for an MRI. Otherwise, an MRI in my books is not particularly useful for assessment of endometriosis. Let's jump to, oh, hi, Suzette, another familiar face. Nice to see your name. I can hear your voice in my head, actually. What is your feeling about routinely capturing a 3D volume of the rectum and the rectovaginal area? So I don't think that there is a role for it yet. I do try and keep an open mind with respect to things that we're not currently doing, which are within the realm of possibility, and maybe we just don't really know what it is going to give us downstream. Um, the thing about 3D, and this kind of applies broadly speaking, is in order for you to interpret a 3D render, you need to know what you're seeing on 2D first. And if you are not comfortable with interpreting something on 2D, it's not going to be any easier to interpret on 3D. It's actually going to be harder because it behooves you to create the output render from the volume that you're acquiring. So I often find what I need on the 2D, and that truly even sometimes is Mullerian anomalies, which is one of the key places that we can benefit from 3D. I usually know what it is from my sweeps before I actually take my render. But I never say never, and always think we should be asking these good questions around what could be around the corner. What secrets could one type of imaging technique hold? And so, if you ever have any interesting thoughts, I would be happy to have a conversation. I'm going to take two more because we're definitely over time. And then anything else I will deal with the on the gram. Um, Courtney says, with superficial endo, sometimes I see small echogenic lesions, but I wonder if it's just from a ruptured cyst or retrograde flow from menses. Scared to call it. Pretty good instinct to have, a little bit of a fear because we don't want to overcall things. We don't want to give somebody a false positive diagnosis. The thing about retrograde flow is that um, it should be mobile and you should be able to shake the content off of the peritoneum if it is settled onto the peritoneum. So this is where that jiggle technique, that dynamic application and release of pressure is really helpful. I actually don't really see this very much. I don't think that we're seeing retrograde flow turn into more tangibly visual lesions versus just some blood and free fluid within the pelvis. So it's not something that I am struggling with to differentiate a lot. And I think a ruptured cyst is probably also something that we're not seeing so much in an elective outpatient setting. This might be something that's more relevant if you were to be working in an emergency department and scanning people during an acute pain flare where ruptured hemorrhagic cyst is a bit more possible. And so if you do see blood clotted in the pelvis from a ruptured hemorrhagic cyst, then I think that's a time that you would definitely want to be delicate in describing things. The other time that it's important to be delicate is any history of previous surgery, any history of previous infection or active infection, because that can result in peritoneal abnormalities. And I just scanned a 70 something year old the other day who has unfortunately endometrial cancer and had a lot of peritoneal irregularities. So, carcinomatosis or metastases from cancers can also be very similar in appearance to superficial endometriosis. Different population generally, but sometimes there is overlap. We can have 30, 40, 50-year olds with endo or with cancer. So, these are the things that you definitely want to think about. And then, okay, I'll take one more. Do you measure the diameter of the ureter? When will define it as dilated ureter? When will you define it as dilated ureter? I do not routinely measure the diameter of the ureter. I only measure it if I have a subjective feeling that it is dilated. I also will consider measuring it if I'm a bit equivocal on whether I have that subjective feeling and if I think that there is parametrial or severe um, uterosacral ligament endometriosis, or if there's bowel endometriosis that happens to have a little bit more of a lateral aspect to it. Sometimes you can have bowel endometriosis sort of encroaching on the 2, 3 o'clock or 10, 9 o'clock aspects of the bowel, if you think of it like a circular clock. So in those cases, I may consider measuring it. Um, there is not great literature to tell us what threshold we should consider hydroureter on pelvic ultrasound at the level of the crossing of the uterine and the ureter, for example. But there's one publication that gives us a cutoff of 6 millimeters. So this is what I use. 6 millimeters is my cutoff. If it's above 6 millimeters, then that flag is raised, and I'm much more critical of where that 6 millimeter constriction point may begin. If I have a uniformly dilated 6, 7, 8 millimeter ureter without any obvious constriction point, then that just may be a normal ureter for this patient, or they could have something such as a distal stone, or they could have something like a mega ureter, something that's not gynecologic in origin. So I start to think about outside the box concepts there. But 6 millimeters is my threshold. All right. Please, to the AIUM team, if you don't mind, just sending me the other questions by email, and whether today or tomorrow, I'll do my very best to pop an answer onto Instagram for you to check that out. And And if you are keen on more content, I have my YouTube channel where I put lots of content as well. I'd like to thank you all again for your attention today. Great questions, great engagement. And thanks again to the AIUM and to Samsung. I will sign off from here, and AIUM, before you leave, has a final message for you all.
Thank you, Dr. Leonardi. And again, AIUM would also like to thank Samsung for participating with us to make this webinar possible. As a reminder, this webinar was recorded and will be available within 24 to 48 hours. Lastly, when leaving this webinar, we ask that you go back to this activity in your AIUM account to complete a brief survey. We would appreciate any feedback you could provide. We will use that to help us plan our future educational offerings. And with that being said, we will close out this webinar. Thanks again for joining us and have a great rest of your day.